Hi, everybody, and welcome. We'll get started in 1 minute, just waiting for more people to sign on. So welcome to the PIHCI Network Learning Series. My name is Jillian Bartlett, and I am the National Coordinating Officer of, I am the Executive Director of the National Coordinating Office of the Primary and Integrated Healthcare Innovations Network. And this morning I happen to be under caffeinated. I'm very happy to welcome you to the learning series that we are hosting this year. This topic will focus on end of life in primary care. And what I'm going to do is give you some instructions on how to use this particular learning platform. And then I will be reading a land acknowledgement and introducing our speakers so you can get to hear their research and thoughts on this topic. And at the end of that, we'll have an open Q&A session. So if you've never attended a Zoom webinar before, it's slightly different from a Zoom meeting. As speakers, we cannot see you or hear you, but we can see your name on the participants list. So you have two ways to communicate with us. One, if you look on the bottom, you will see the Q&A. If you click on that, a box will pop open and you can add your questions. You can do this anonymously or with your name. If you put your name there, I will probably acknowledge your name. If you say anonymous, I'll just say this is a question from the attendees. I will be reading these questions during the Q&A for our panelists to answer. If you have comments, so it's not a question, but it's an observation or something you want to share. If you look at the chat, you click on the chat button, you have two ways to make comments. You can make comments to everybody. That would be all the panelists and all the attendees. I would prefer that you use that option. If you have something specific, like you want to say thank you to a speaker, you can pick one of the panelists or the panel to communicate directly. All the other attendees won't see that comment. So those are the two unique or three unique features of a Zoom webinar. So I am going to, I will talk to you about how the session will work. I'll read the land acknowledgement and we will get started. So we have 4 speakers today, and this session is co-hosted by the Nova Scotia PIHCI site, which is Brick, Nova Scotia. So we'll also hear from Jessica Nolan from that site at the beginning. Then we have 3 researchers presenting, and today Ghislaine, I gotta get her name right, Ruli is our patient partner who will be sharing some of her experiences before we move into the Q&A. So I'm going to right now read a statement of acknowledgement of traditional land. This was developed by the Canadian Family Physician, the College of Family Physicians of Canada Indigenous Health Working Group, and they allowed me to use this statement since we're coming from all over to join this webinar. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. We invite all attendees to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Thank you. So I will now ask Jessica, who is representing Brick, Nova Scotia, to present that site and before we move into our speakers. So Jessica, go ahead.
Great, thanks so much. I just want to make sure, are you seeing my slides?
Yes, we are.
Okay, perfect. So thank you so much, Jillian, and thanks for giving me the chance to speak very quickly today. I know we have some really exciting presentations to get to, so I won't take a lot of time. So I'm Jessica Nolan. I'm the manager of Brick, Nova Scotia, which is our Nova Scotia PIHCI network. And we're really excited to have these 3 projects highlighted today, which are all led by BRIC-NS members. So I just want to quickly discuss some of the ways that BRIC Nova Scotia supports research projects in their development. So our mission, along with that of the other PIHCI networks, is to make more primary and integrated healthcare research happen, especially research that will impact patient and health system outcomes. So I wanted to highlight a few things that we do to kind of help this process along. So one of those is forming research teams. So the projects that are being discussed today were all funded through grants from CIHR specifically for PIHCI network members. They all had requirements to have decision makers and patients as part of their teams. And one of the things we do is we can help research teams make these connections with these different stakeholder groups. The second thing is connect and form collaborations with teams in other jurisdictions. So again, all of these projects needed to involve members of at least one other PIHCI network. And so the network managers helped to form some of these cross-provincial connections when it was required, and also making sure that the participating networks are aware of the application process and signing off at the appropriate time. And then finally, help in developing successful research proposals, which I'll talk about on another slide. Oops. So I wanted to just quickly talk about our project incubators, which are events that we created to bring people together in anticipation of these special funding calls, with the goal of creating teams and research questions ahead of time so we'd be ready when the calls were announced. So the projects being discussed today either developed at one of these events or stemming from conversations and relationships that started at one of those events. And after the PIHCI calls were all rolled out, we've switched the focus of these a little bit. We focus in on a specific area of research, but we've continued to be successful in helping to put teams together and helping them apply for research funding. So everyone in our membership is welcome to attend, and we've had about 170 participants since we started them in 2015, including people working in the healthcare system as decision makers, researchers, patients, students, and healthcare providers. So some of the specific supports that we can provide to teams as they're developing proposals for research funding is, to help identify members in other PIHCI networks, like I mentioned, help with collecting CVs, identifying data sets that might be available to help answer the research question, help with creating budgets, reviewing proposals for completeness and making sure that what the funder is asking for is being answered in the proposal, providing letters of support, and then also as we see successful projects funded, providing a platform for knowledge translation and exchange. So we do other things and we hold other events, but I just wanted to highlight some that are sort of specific to project development. So you can go to our website, which I think Anik will put in the chat. And if you're not in Nova Scotia, I'd encourage you to go to the Network Coordinating Office's website, sporpihci.com, spor-pihci.com, and you can connect with the relevant network for your jurisdiction there. So thank you very much, and I'm looking forward to hearing from everyone today.
Thank you, Jessica. It's great to hear from our co-host and to hear what you're doing. I can testify that Nova Scotia is doing some really great, exciting stuff, and it was lovely to meet them before we had something called a global pandemic. Okay, so now I'm going to ask our first speaker to pull up her slides. This will be Grace Warner, and she's going to be talking to you today about barriers and facilitators to initiating end-of-life conversations, assessing patient and caregiver needs, and patient and family-centered planning in primary care practices, which is a realist review. And she's going to cover all those topics in 10 to 15 minutes. So, okay, Grace, we can see your slides, but still in slide, they're not in slideshow yet.
Okay, good. Well, thank you very
There
much,
you go.
Jillian. I appreciate that. I was just kind of waiting for you to finish until I kind of got all set up. So welcome, everyone. As you can tell, it's a long title, and I didn't realize that it is a realist review. So I'll go a little bit into the methodology about that. And I was pleased to, when I looked at some of the participants, that I see some of the people that I've worked with on this, especially, hi, Joanna. for being on here as participants. So that's really nice to see because we had a great group of people working on this. So first off, I want to acknowledge that we did get funding from the CIHR SPORE PIHCI Network Knowledge Synthesis Grant. And also we had a lot of in-kind support from Nova Scotia Health, the Maritime SPORE Support Unit, and definitely thank you very much to our participating family caregivers advisors, Joanna, which is one of them. And then I'm going to just do a little bit of background just to kind of put us in the right frame of mind of what I'm talking about. So this is about primary palliative care. So it's a part of the palliative approach to care. So what we're looking at is very early on into the right there in terms of when you go from self-management kind of going towards a trajectory towards end of life. And so a lot of you may be familiar with this because of the topic that of all the presenters today. So really thinking about, so I'm really taking this from the work of Scott Murray in terms of thinking about it, calling it primary palliative care, and to think about what happens in primary care when you're looking at the palliative approach to care. So it's really focused on patient and family communication. That's a really critical part. Looking at goals of care, help with advanced care planning. And when I say advanced care planning, I'm really thinking about a very broad idea of advanced care planning. And then the psychosocial, spiritual support, and of course, end of life care that fits into primary care settings. So I'd like to kind of get us around a frame of what is advanced care planning. So if we look at the SADOR definition, it is a very broad definition. So we're not just thinking, we're thinking very broadly about understanding, sharing personal values, life goals, preferences for future medical care. We're thinking about people who not only, and medical care is consistent with their values, goals, and preferences during serious and chronic illness. So we're very much thinking about a comprehensive plan. So when you look at some of our findings, think about that way of thinking about advanced care planning. So just a little bit getting into the methodology, because a realist review is quite different from other types of reviews. It's very iterative and it involves a lot of consultation. So we had a lot of consultation from our family advisors and also from our health system users and knowledge users, sorry about that. And then we researched synthesized the research evidence that we found, but it's a very iterative process. So I want to get into that process just for a couple slides. So a realist review is like it starts out, we started out with a consultation with our knowledge users and family advisor about what's the question we want to ask. That was right at the beginning. And then as soon as we got funded, we went back to them again and said, okay, now what are we going to do? And then we're always trying to think about the realist methodology, which is a very specific methodology. Since it's newer, it has a bit of a, make sure that we're following the rigorous methodologies that have been instituted, through a lot of the documents and training documents. We always are going through, then we search the literature. So we did a lot of different searches. We did 2 systematic searches of the literature, other what we would call purposive searches of the literature. So that's really digging down deep into certain literature where we're trying to develop program theories. So program theories, I'm going to talk a little bit about that next. So you can see it goes round and round. And so it's not just kind of go to the literature and synthesize literature. You have a lot of consultation. Okay, so here's a little diagram from Dalkin to kind of give you an idea of a realist review. So if you want to look at that, you've got resources that kind of come in. So you think about training or something like that comes into a certain context. So that would be a primary care practice setting. And then that interacts with people's, the context and the resources interact to create a difference within the individual in terms of their ability to, they feel more comfortable, they feel like they can do end of life conversations, participating in that. So what the realist way of approaching things is, we want to understand what are the resources come in, how are they how do they work or don't work depending on the context, and then what are the outcomes for that. So in our realist review, we searched quite a bit of the literature. We had 2, like I said, 2 systematic searches of literature. We screened over 2,389 articles from our initial search, and there, like I said, there was another systematic search and particular in-depth searches for that. And so that was that took we ended up with 29 articles after all of that. But along the way, we're continually developing these ideas. So when I say program theories, I'm thinking about what works, in what context does it work, and what are the contexts that support or hinder that. So that's really what I'm going to be focusing more on now in this presentation. I didn't want to get into a lot of the references or things like that. Be happy to share that at a later day if people are interested, or the different, the level of evidence for each of the studies. So I'll just kind of go for the high level of the findings. So these are the key findings. Using tools or discussion frameworks can facilitate assessment of needs and planning. Transitions or opportunities for conversations and planning. Important organizational facilitators, because we want to look at all those contextual levels, not only in the practice setting, but maybe in the healthcare and also at the individual. So healthcare system over there. And training helps communication. And then in the end, end of life conversations and planning can improve outcomes on different levels. So digging into this first one, using tools or discussion frameworks can facilitate assessment of needs and planning. So the literature shows that if providers use tools or kind of a way of talking, like a discussion framework, then that does facilitate end of life conversations and planning. I put them and assessment and planning. So really the conversations and the needs assessment kind of go together in that whole thing. And the use of tools allows the practitioner to kind of take a step back and not feel that they have to confront the patient right away with end of life discussions. So it allows them a little bit of distance and allows that ability to assess what's going on. And it allows the patient and family members to think ahead on what they see as coming. And once again, going to Scott Murray's work, I mean, the use of general questions can also kind of, if a tool is because we know from literature, it's hard for people sometimes to use tools within practice. So maybe the use of general questions might work just as well. But the key is to kind of assess needs to introduce topics associated with end of life and to help structure or conduct comprehensive advanced care planning. Secondarily, transitions, opportunities. So the idea is to be aware in the primary care setting of when these transitions are happening. So when is that readiness for those end of life conversations might be heightened. Because we all know as we go through transitions, through different healthcare settings, it can be quite a kind of hard time for people to go through it. It might be a time for reflection to say, okay, what needs do I have that are not being met? So these are a really good time for primary care practices to have those conversations. And once again, to use tools, assessments, or use the general questions, depending on the comfort level of the provider. Okay, important organizational facilitators. Once again, because we're looking at this as a realist review, what we want to understand is we want to understand the context that they facilitate end-of-life conversations, assessments, and planning. So having enough time and resources is a constant thing. I heard it many times. So drilling down into that, rather than saying we don't have enough time, we don't have enough resources, which is true, is to think about what is that, what are the consequences of that, and what are the reasons for that. So it really limits opportunities for initiating these conversations. It can impair practitioners' abilities to have trusting relationships. And what's the reasons? And one of the hypothesized reasons might be there might be a different prioritization of time. If it's a busy practice office, it's really hard to balance all those competing needs. But practice routines is another area where this might make spaces for those conversations, is that, having a practice routine that allows the space for those conversations to happen is very important. Another thing is organizational commitment. So organizational commitment to kind of having the team very supportive of having this happen, embedding the use of tools or assessments into different practice routines. So it just kind of happens routinely. How do you do it? How do you make it happen? And then it just kind of happens more in a more fluid process. Let's see, practitioners with disciplinary backgrounds. So certain disciplinary backgrounds might be more conductive to having these end of life conversations. So for example, social workers might be more trained in this area, so they might be the ones to do it. Also, having group discussions is a way to do it, which the literature shows. So these are all things that have been supported by the literature. I'm not putting references in here just to make it flow as a conversation, but these are all things that the evidence shows us that are important. And also getting into like, what is that? How do we normalize talking about death? Because it's a it's difficult conversation to have. And so that's really about things about the compassionate communities that are evolving. Also, these can catalyze social change, which make the patients and family members more ready to have those conversations. Training, and that's when you looked at that slide that I showed you before about resources coming in. So training is one of those things that can come in. But training, as we know, it's not just about education, it's about the readiness for the education. Provider attitudes have a huge effect on whether training is effective. So you really have to look at readiness in terms of whether the practice is ready to do this, and whether they can, what are the obstacles to implementing what they're being trained to do. So we have to look at but we know that with training and with the right readiness, that it can improve both their competence and skills in having end of life conversations and doing planning in primary care practices. So the literature does show that, when these things happen, they can improve outcomes, both at the patient and family level and at the health system level. So with this facilitation of conversation, patients and families are better prepared for end of life events and bereavement, which can be quite a difficult situation to handle. Increase family members' confidence caring for patients in their usual place of residence, so they feel more prepared, because we know how much the system does rely on family members, or I'll use the word family friend caregivers to be more inclusive, that the system does rely on that. And so we have to help them with that process, which is why I've also emphasized the fact about patient and family-centered care, because I like to think of them as a unit. Health system, less likely to use aggressive life-sustaining medical interventions, lower rates of in-hospital deaths. Once again, there are times when it's appropriate to have an in-hospital death, but there are times when both the patient and family support an in-home death, and that should be respected and allowed whenever possible. A decrease in healthcare costs, and at the end, another thing about health systems is, and Alex will be talking about this a bit more when she talks about the Emerge and about, the special patient program, and also Robin when she talks about different programs, is that we need that connectivity within the system, which we don't have now. And maybe some places do, but I know that, health systems constantly struggle with how do we, how do we translate plans and have them communicated across different sectors. Okay, so just a final slide, or final two slides. So I think the last one is a question mark. So just to get an idea, so when the yellow boxes are about context that we need to think about, the grayer box is a little bit of understanding about what is that context mean. So in the middle, end of life conversations, assessing patient and caregiver needs, patient and family centered planning. So if we take this in, so if we have training, we have interdisciplinary teams, we have the use of tools, and we have awareness of transitions, that's going to make this more likely to happen. Secondarily, we put in practice routines, space for conversations, patient population, like if it's a larger geriatric population, maybe there's a larger readiness for this to happen. And an organizational, when I say organizational, can be both at the practice setting and at the health system level, in terms of organizational commitment to making this happen. So this can lead to alignment with patient and family goals of care and decreased health system costs. Well, so I do have another one, implications. So primary care settings are the appropriate place to initiate end-of-life conversations and planning with patients and their family friend caregivers. Policies need to create structures that facilitate a primary palliative care, or a palliative approach to care, if you want to use another frame. Research, more research is needed to know how do we make those connections between sectors work well. Opportunities to improve the context for end-of-life identification, assessment, and planning. The initiation of collaborative care teams, which I know we're doing in Nova Scotia, integrated palliative care policies, and strong leadership in the health authority. So I want to thank you. I do tend to talk rather quickly when I'm doing a presentation, so I hope that you all got that. And if there's time for questions, I'm good. I wasn't monitoring any questions. I'll turn it over to Jillian, and I will
We're
stop
gonna
there.
we're gonna take all the questions after everybody has spoken. So thank you, Grace. That's really appreciated. So our next speaker who will pull up their slides is Alex Carter. And I keep on thinking one of my computers is a touch screen, and it absolutely isn't. So Alex is going to be talking about paramedics as part of an integrated patient and family-centered approach to end-of-life care. And Alex, if you want to put on your, there you are. Okay, and this is your slides, but still not slideshow. Our greatest challenge in Zoom is getting the correct slideshows.
Yeah, I just want the little bar to move out of the way so that I can reach the thing that says run my slideshow.
Yeah, I wish I could reach to the screen and help you out because I can see the little thing that you need to click on.
Oh,
Oh, you just canceled. It's okay.
let me just open it again.
Yeah, no problem. I think if you click on slideshow at the top.
I can't, right, I
Okay,
can't
then
reach
on
it.
the bottom, can you reach, so you see the bottom, the little thing that looks like a box on a stand? That does the same thing.
Right. Oh, okay.
Yeah.
Yeah, no, it's just the controls for Zoom are covering up. Like, if
Okay.
you see what I'm saying?
Yeah.
Top. Yeah. Okay, we're good.
There you go. You're good to go.
Okay. All right. Well, thanks very much for the opportunity to talk about some of our work with this group today. And I'm presenting on behalf of a fantastic team who have been very instrumental and supportive. And of course, the support for the piece that we're going to talk about today from the great group at Nova Scotia. So what I'd like to take a few minutes to present to you is the idea that paramedics can be a very important part of an integrated approach to palliative and end-of-life care. And I'll tell you a little bit about how we arrived at that. This particular project was funded through one of the SPORE PIHCI CIHR grants. And of course, partners here in Nova Scotia, including Emergency Health Services, and our operator EMC and the MSSU, the Maritime SPORE Support Unit. And then we worked with the SPORE network in British Columbia for this project as well, and the UBC Centre for Health Services and Policy Research. So this idea came about when we realized that paramedics are actually called by members of the public to respond when their goals are not, in fact, transport to the emergency department, which is what you often think of paramedics doing, but are in fact to assist with pain, breathlessness, nausea, other symptoms that people are experiencing, but they actually want to stay home. And that was sort of a big kind of watershed moment for us when we realized that this happens often enough, that it was an important part of the work paramedics were doing, but that our system was not set up. Paramedic systems anywhere in the world were not really set up to do this kind of response, to provide medications and support and keep people in their home. The expectation was always that you would transport to the hospital. Some of those people were already connected to other home support programs like a VON nursing program or continuing care or palliative programs, and some weren't. But whether they had those other supports or not, they told us that sometimes they still called 911. And that could be because their usual supports like VON or continuing care, palliative care teams were going to take longer than they felt was going to be okay. So there was a delay, or they simply weren't available at that time of day or on that day of the week. They felt that they needed a more rapid response. And it is a very emotional situation. And they would feel perhaps the panic moment that you call 911 when you need help. And so in response to that, we developed this Paramedics Providing Palliative Care program, which has 3 key pieces. One, there's a clinical practice guideline or protocol now that is actually called palliative care. So it's no longer driven by this is the pain protocol or this is the breathlessness protocol. It shifts the emphasis to providing symptom relief and support and emotional support to the patient and their family in the location of choice, and has the option of remaining home if that is what the person and their family would desire in that moment. That was supported with an education development of new education for paramedics. We initially worked with Pallium Canada to develop a course for paramedics. And since then, in 2015, some other education options have been developed as well. But the key there is that there needed to be specific education for paramedics to support this new practice. And then some kind of a database or a system by which you could make those care wishes, the goals of care, actually known to paramedics in a format that they could follow, because it was consistent with what they're allowed to practice, their scope of practice, and was accessible in real time in sort of a mobile environment. So in Nova Scotia, we use something called the Special Patient Program, which is a database of individualized care plans to enable this, but other programs are using their own version of that. So those three key elements, and we launched that program in Nova Scotia and Prince Edward Island in 2015. Since then, we've done a bunch of work to try to understand better how it works, how it could work better, different things that we might need to work on, and how to spread and scale it to other jurisdictions as well. So the program itself was actually built through a research methodology, a consensus building Delphi exercise. And then we asked paramedics about their comfort and confidence with the program before and after we launched it. And we're happy to find out that paramedics are in fact more confident in providing this type of care since the program launched, and they have the formal infrastructure to do this. We're very happy, of course, to find that patients and families are very happy with the program. For the, not to say that it's all roses and there's always things we can learn, but that generally things that rank very highly are the 24/7 availability of paramedics within a very timely response, the relief of symptoms that enables people to stay home if that's their preference, and the compassion and professionalism of the responding paramedics. Basically, every interview we've done has mentioned that, which is quite a testament to the care provided by the paramedics. We also asked important questions around the operational feasibility of this and whether it was going to take a lot of time away from providing other types of response. And we're happy to say that it does not. It's quite sustainable. It also is a good fit with paramedic professional identity. And we're still looking at a few other things, like whether there are differences for rural populations or older, frail populations. The early emphasis was largely through our formal palliative care programs. So that's how patients became aware of this and their families. And so that was a lot of oncology, cancer type diagnosis, but this has now spread into other programs. We have through the heart failure clinic, through the lung disease clinic, and into primary care referrals as well. And so lots more emphasis now on non-cancer conditions, looking to understand whether there are needs now that we hadn't anticipated because of that. And then an important piece that Grace also alluded to is that importance of sharing across the continuum. So the goals of care that we have on the paramedic tablets, well, they don't end when the person does arrive in the emergency department, whether that's where they wanted to go or whether they have some needs that couldn't be met. Some people do still end up being transported by paramedics. And so we're working on a way to share the information that we have at EHS with the receiving emergency departments. Also exciting that this has caught on through the Canadian Foundation for Healthcare Improvement and CPAC have now funded a national spread collaborative. So you'll see this popping up in other jurisdictions across Canada, and we're a couple of years into this spread collaborative, and it is going live in a couple of these other locations already. So bringing us to the specific piece of work supported directly by RICNS and the SPORE PIHCI network. We looked at two pieces. We looked at determining the essential elements for spread and scale of this model of care through an exercise of deliberative dialogues. And that had participants from Nova Scotia with the program and BC without the program. And I'll tell you a little bit about that. And then we also looked at our data to see if in fact it achieved what we were hoping, was that people spent more of their days at home in the last 6 months of their life. So first, a little bit about the deliberative dialogues. So we brought together groups of people who had been key in implementing the program in Nova Scotia. And then we brought together a group of people who would be those who would implement it in British Columbia if they chose to go forward. And we looked for themes in the dialogue, the discussion that came out of those sessions. It was used a guided kind of structured discussion, and then we transcribed the discussion and looked for themes within that. We used a template called the Consolidated Frameworks for Implementation Research to guide that coding, and it divides things importantly into inner setting, so the setting in which you're implementing it, versus the outer setting, things that are outside, like external policies that might influence the implementation, characteristics of the intervention itself, the process, and characteristics of the individuals implementing it. So it can help us know where to go looking if things needed particular work or particularly could be leveraged in different settings. I'll highlight a couple of the key themes that came out. This is the most important one, was in the outer setting, so factors outside the intervention itself, the construct of cosmopolitanism, or the idea that you needed to reach far beyond the borders of your own organization. And we heard lots of feedback from the participants that very early and really meaningful engagement of stakeholders was critical, and that a barrier to this would be the lack of intersectoral communication due to things like incompatible information technology and privacy requirements. So this is the number one thing that teams looking to undertake a program like this would need to tackle, would be the idea of breaking down silos and bringing people together who'd probably never been in the same room before. Another one that's really important, and especially as we started to engage with primary care, was around, again, the outer setting, outside the intervention, around patient needs and the theme of being clear on the expectations. The facilitator to this was that there was a clear need identified in the community, but a barrier, an important thing to look at, was a way to get families and also providers like family docs and family health teams aware that this is something paramedics can do, but also to be very clear on what paramedics can and can't do. It was important as we looked to spread and scale that we thought about the characteristics of the intervention, and in particular, the adaptability to different settings. So essential that you have the EMS training, but that it be adapted to suit local needs. And then the individuals themselves, the paramedics, how do they feel about this? And they actually expressed a strong desire to practice differently. It is desired by paramedics to have a new way to support these patients, and their families. But there is certainly a fear of increased responsibility and a resistance to change, and in particular, in places where there wasn't a lot of this treat and release or treat people and leave them at home, that was quite a shift in culture that would have to be overcome. So those were key elements to the spread and scale of the program. The other piece, as I said, is that we wanted to look at whether people actually got to spend more days at home, and whether people also got to die at home. But both of those things were important in and of themselves. We've done this work for the Nova Scotia data set. We're also doing it in BC, and I don't have that final analysis yet. And so we had about 10,000 people before, in the 18 months before we launched the program, who died in Nova Scotia of non-sudden conditions, and about 14,000 in the period after. This is an older population on average. And you can see, I think, even just looking visually at the graph, that people got to spend more days at home in the final 180 days of life. So that tall bar over on the right-hand side at the got to spend 180 days even of their 180 final days at home is bigger after the program launched. And this is based on the whole population of everyone who died, not just the people who were touched by the program. And we want to be able to drill down a little deeper into this eventually, but we can definitely see from this that people got to spend more days at home after the program launched. We also looked at the odds of them being in the emergency department during that time and the odds of them being hospitalized in that time. And the odds were greater that they would spend days in the emergency department or in the hospital in the period before the program launched. So again, decreased odds of going to the emergency department or going to the hospital. And then thinking about location of death as well, you can see that deaths at home increased in the time after the program launched, and deaths in hospital correspondingly were lower. We don't have a hospice, or at the time did not have hospice in Nova Scotia, so the only two categories really were home or hospital. This would be different now that we have hospice here as well. So before the program, there's a 44% increased hazard of dying in the hospital. Interestingly, as soon as you get hospitalized once, your odds of dying at home go down significantly. So keeping people out of the hospital is and providing some kind of structure for them to be able to stay home was a big part of it. These are the things that make me smile every day and remind me of what's important. And I'm happy to follow up at the end with questions when we have the panel questions. And here's my email address if anyone thinks of something after today.
Thank you, Alex. And Nick will put your email address into the chat for those who would like to copy it. We are now going to move to our next speaker, who is Robin Urquhart, and she is going to be talking about innovative programs to help individuals and families affected by life-limiting chronic illness navigate end of life. And this is another realist review, which are always interesting because we get some insights from them we might not otherwise have. So Robin, you're good to go.
Thank you. For those of you that saw me earlier before we started today, I've had to move locations because the sun is shining quite brightly into my space right now. So I'm going to talk about, as was said, innovative programs that we're studying programs that help individuals and families who have life-limiting chronic illness sort of navigate the health system and sort of community supports and services as they get closer to the end of life. So this is a very large team. So I did want to bring everyone up here, and we're situated mostly from coast to coast. I'm from Newfoundland, so I shouldn't say coast to coast, but certainly Nova Scotia to BC. And I know there's a number of people on here today. Certainly Grace, who presented earlier, is a member of our team, and Joanna, and I saw Bev was on, and probably others, and Cheryl, I think, as well. So it's great to have you guys on today. And I do have to talk about our funders. So this was funded through the Canadian Institutes of Health Research, of course, but you can see we have a number of matching funders and in-kind funders, again, from sort of BC, Ontario, and Nova Scotia. So the context here. Essentially, I put a few references here, and I have them later. But when we look at research from Canada over the last decade or two, really, we do see that the care that we provide to those individuals who are approaching end of life. So I'm using the term end of life, but I don't specifically mean sort of weeks or months before death. I see end of life. I'm very much more upstream than that, and we'll talk about that in a bit. But essentially, we see that really this care is often fragmented. It's often hospital-based. Research in Canada has also showed us that there's a lack of, patient awareness, family awareness, but also provider sort of awareness and knowledge of what programs and supports are available for people with life-limiting illness. And this can lead to poor care coordination and, say, choppy transitions across healthcare sectors. And I know Grace had talked about that earlier. We also know that both providers and patients have reported, I guess, or discussed that the current arrangement of providers and services and referral pathways and so on really is confusing for them and difficult to navigate. So when we put together this proposal to send in to CIHR, we really saw that there was a critical need in our country for programs that help people figure out the system, I guess is what I'm trying to say. So that help people with life-limiting illness, navigate the complexities of our healthcare systems and really, increase people's awareness of and sort of access to the services and supports that they need to achieve their goals of care and their goals for life as they approach the end of life. And that we certainly I've focused a lot on sort of remaining in your home and your community for as long as possible. Certainly, if that's what you want. So one potential approach, really, that we came up with, or that we discussed, was sort of the use of navigation programs for people with life-limiting illness who live in the community or community dwelling. So these programs that can sort of educate patients and families, link them to sort of really critical health system, but also community services and supports, again, to help them, to help people achieve their goals or meet their goals as they approach end of life, and to facilitate coordination across sectors, across healthcare settings. So we're talking about navigation programs here, and I am from sort of the cancer world. Most of my work is in cancer, and of course we do know that in cancer, models of navigation and health navigation have been shown effective at improving access to certain services, such as cancer screening and treatments, particularly for groups of patients who are sort of more vulnerable. And there is more and more work being done in terms of navigation, health navigation, for people outside of cancer, right? And for people with life-limiting illness. And some of that certainly is going on here in Canada as well. And that has shown things like reduced hospitalizations as people get closer to the end of life. So we decided to study navigation programs across the country. And our objectives were really to identify innovative navigation programs that exist right now in Canada, and articulate the principal components of those programs. What is it that allows them to meet the needs of their clients and patients with and families with life-limiting illness? We also wanted to compare how well these programs improve individuals and families' navigation within their communities and navigation of the health system, how well they're integrated into primary health care, and how well they support end-of-life goals. So that, again, would include sort of preferences for care as someone gets closer to the end of life. Our conceptual approach, so I don't have to go through too much of this because Grace talked about it, but our conceptual approach was really a realist evaluation. So slightly different than what Grace had talked about earlier, because Grace had been talking about a realist review. So she went into the literature and did a review about the evidence that's currently there. Instead, we undertook very similar work, but a realist evaluation. So we are collecting primary data, collecting data from these navigation programs that we've identified across the country. And really what we're trying to figure out is what works for whom and under what circumstances. So we're not trying to figure out whether something, in this case, a patient navigation program or a navigation program, we're not trying to figure out if it works or whether it works or doesn't work. We're really trying to figure out, what's working, why is that working, under what circumstances does it work, and so on, and to produce which outcomes. And so at the end of the day, I put this question up here, but at the end of the day, this is really what we're hoping to do with our project. So again, if we, so from a decision maker perspective, we invest in community-based navigation to help people who are living with life-limiting illness plan for and achieve their goals as they approach end of life. You know, where should we target it? How might we best implement it? And how can we maximize its impact? So that's sort of what we're trying to get at the end of the day in terms of the information. So we've undertaken the work in 2 phases. So we have not completed this project yet. So there's the spoiler alert. But essentially we had the first phase was an horizon scan, or sort of like an environmental scan. And we had to identify these programs. So what exists across the country. And we did that through 3 means, really. So again, our research team actually exists across the country, and this is something we're interested in. So we have some knowledge of what's happening already, right? But the first, so we did some gray literature searching, reports, went to organizations who might support this sort of work and so on. So we did gray literature scanning. We also did a number of web searches for each province and territory. And we did a nomination method. So we probably got most of our possible programs through this nomination method. And what we did was we sent a sort of request for nominations to research, to clinical, to policy leaders, mostly in palliative care, in all provinces and territories. So we sent out a minimum, we sort of identified a minimum of 3 people that we thought would have a good understanding of what's happening in their jurisdiction. And we sent out a request for nominations with sort of selection criteria and, you know, information about what it is that we were doing. And individuals were asked to nominate programs that they knew about in their jurisdiction or in other places, right? Could be a different province as well. And then to provide us with the name of the primary contact. I just want to bring this up. We did have selection criteria for these programs. I don't want to go into it too deeply, but essentially we wanted it to be, we call it a formal program, but you know, it has a governance and accountability structure. I mean, the idea again is to sort of provide decision makers with information around what works, why does it work, what do we need to target to make it work, and so on. And so we were looking at sort of these formal programs that could be put in place, I suppose, and have a governance structure that we could describe yeah, I mean that we could describe and so people could replicate it. The program had to serve community dwelling adults with chronic life-limiting illness. The program could be situated in the community or in a hospital. So they could be programs that are sort of situated in a hospital setting, but really they're serving community dwelling folks who are in the community. Patient navigation had to be a primary focus of the program. We struggled with this, to be honest. Like, you know, how do we determine if patient navigation is a primary focus? I mean, I believe at first we sort of had it as the primary focus. But really some programs, you know, do a lot of different things, but it had to be a primary focus of the program. And we did base that upon the literature and upon sort of definitions, conceptual definitions of patient navigation. So I won't read this out, but essentially it was based in the literature. The other part was that the program had to sort of encompass a palliative approach to care. Again, it wasn't about palliative care, and it wasn't necessarily what the work we're doing is not really about end of life. It's about people who have chronic life-limiting illness, and you know, as they are, you know, eventually, I suppose, getting toward the end of their life. But we're not talking about the last weeks or months or something like that. So they had to encompass a palliative approach to care. Again, this was sort of based in the literature. So we defined it based off a number of papers that came here. Actually, the previous one is from Canada as well. Both papers from Canada. And, you know, I've highlighted a few things, but essentially the patient and family are viewed as the focus or the unit and focus of care. You know, the program is addressing whole person needs, acknowledging the life-limiting nature of an individual's chronic illness, you know, knowledge and expertise from specialist palliative care, and an upstream orientation. So again, it's not just in the final days or weeks. It can be implemented at any point in an individual's illness trajectory, in any setting by any provider. So what did we find? We actually found that we got potentially identified across the country. So interestingly, what we set out to do when we wrote this proposal and submitted it, we said, you know, we can't possibly study 30, 40, whatever. We didn't know how many programs we were going to get. So we really needed to, we said we'd study in depth a maximum of 15 programs. So gather data from 15 programs. And we needed sort of what we would call information rich programs. So we needed to be able to interview folks who worked in the program, maybe decision makers of the program, clients, families who sort of accessed the program. So to get sort of a range of perspectives, also sort of get any documents like related to the program that we could study, evaluations that have been done, and so on. And so in the end, so we went through a very iterative process. We as a team, we met numerous times with this list of programs to decide which ones we felt would give us the most, or most information rich is the term I'll use for our realist evaluation, and which ones had different contexts and so on. Those things were important, but also sort of aligned with the definition of patient navigation and the definition of a palliative approach to care. In the end, we decided to collect sort of really in-depth data on 12 different programs. And you can see where they're located here. 5 of them are in Nova Scotia, 4 in Ontario, and there's 1 in PEI, 1 in Alberta, and 1 in BC. And we really felt, again, I think I have the realist evaluation here, but we really felt that these 12 programs met the criteria and would allow us to develop really good program theories to help explain, you know, what's working with these navigation programs, why is it working, for whom is it working, you know, what are the outcomes of the programs. So, you know, Grace talked about this, and I don't want to get into it too much in terms of the these sort of context mechanism outcome configurations, very similar to what Grace was talking about. We took, on the advice of Grace, the same sort of approach from Dalkin in the UK around understanding, really taking this approach. So thinking about developing these program theories in terms of thinking of like certain resources are added to a specific context, right, to a specific setting. So those resources, again, could be training that's provided, could be funding resources, could also be you know, the time, the space to actually sort of, you know, work with clients and patients, to actually work with families, the time to figure things out with them and to figure out what it is they need and how we're going to address those needs. They're added to a specific context or specific setting. This will trigger people in that setting to sort of have certain reactions or to have certain reasonings, right? So perhaps it's, you know, an increased ability to advocate for patients and clients and their families. Perhaps it is sort of a really sort of deep valuing of person-centered care, person and family-centered care. And the interaction of those sort of the context and sort of those reasonings and reactions will lead to certain outcomes, whether those are positive or negative. So the point where we are right now, and I'll clue up, is we're actually interviewing, so we're collecting data still. We've collected data, and it's very iterative, as Grace said. We're collecting data, we're developing these preliminary theories right now, bringing them back to other members of the group, bringing them back to other team members, and over the next month or two, we'll be bringing them to sort of our knowledge user folks to have some preliminary discussions, to our patient and family team members, and sort of to refine those theories. And then we're going back and collecting more data to, again, sort of test those theories, to refine them more, and so on. So it's a really iterative approach. At the end of all this, what we're hoping to produce, I guess, or have, is you know, there'll be a case book of innovative navigation programs. So those 12 programs that I just sort of talked about. And I should say some of those programs, some are situated in the health system and some are sort of community-based, charitable sector, and so on. And we will, have a series of program theories, again, to sort of identify and explain what's working, to what effect, under what circumstances, and to what effect. And I just put this this question up here again, because the goal of our team is at the end to have these program theories that can help us address this question. Those are my references, and that's it. Thank you very much.
Thank you. And we are now going to hear, I'm just mindful of the time, but we do want to give adequate time. So Ghislaine, if you want to turn on your camera, she's going to share her perspective as a patient partner. And then if there are any questions, I encourage you to use the Q&A and we will do as many questions as we can. But Ghislaine, go ahead.
Thank you, Jillian. I'm a patient for the last 74 years and a patient partner for the last 10 years, we'll say. As a patient and as a mother who lost her 20-year-old daughter to cystic fibrosis, I've been involved with end-of-life and palliative care for early on. And I start to accompany patients who were around me and didn't know, need help and so on. So this is how I start to accompany people at the end of life. I got really interested and I was looking at what was going on, and I decided that maybe I should take some training, which I did, and so on and so forth. And now, many years later, I am the co-leader and co-researcher for you call a action research named community, caring community. And this caring community has different volets, different branches, let's say. And one of them is a compassionate community. Dying is a societal issue, not a medical issue. Community connection and support are critical to living well to the very end. This is something that Alan Kelleher, father of the concept of the compassionate community, started in the UK many years ago. Several hundred compassionate communities have been implemented and evaluated around the world, but this model remains relatively unknown in Canada, but for BC and Ottawa. And the Canada Research Chair on Partnership with Patient and Public also joined with the Montreal Institute for Palliative Care, instigate a 5-year action research project aimed to co-construct, implement, and evaluate 2 compassionate communities in Montreal, in 2 different boroughs, one a very, let's say, wealthy borough of Montreal, and the other one in a very limited borough. So what is a compassionate community? In fact, it's a group of persons made of those who are worried and interested in the quality of life of the members of their community. A compassionate community gets involved in the care and support of those living with advanced illnesses and at the end of their life. People are implementing initiatives, increase awareness, and offering training. They work together in order to build a skilled society that is able to face illness, death, and bereavement as part of life. And it's interesting to see that in the community, whether being a tattoo parlor, for example, very often we don't realize, but some people, when they lose someone, they will go and have the name of their loved one tattooed on them. So you know who these people are. You can reach Maybe some of them need help. And so the community is very much involved. You can also involve the postmaster. You can involve the bakers. It doesn't matter who it is. As long as you have a neighbor, then you can take care of him. They work together in order to build a skilled society that is able to face illness, death, and bereavement as part of life. Community partners such as city councils, corporations, schools, organizations, families, institutions that care for patients at the end of life. Also with skilled medical and social service professionals. So the entire society benefits from it. It's really, when you look at it, when you see one really, and that you realize that each little gesture, each little word that you can give to another one, it does help, and it's really important. In our research, we are implementing 2 in Montreal. And like I said, one in a very disadvantaged neighborhood, and the other one, like I mentioned earlier, a more privileged. And already just that we are at the beginning, it's a 5-year research. And in the first year that we are now, you can see already the differences. The care is different. The interest is the same, but the care is different. The way of going to know your neighbor is entirely different, and we are learning from that. So it's, in a nutshell, it's really what we are doing right now. Patients are really involved with that, and to take care of that will also imply some patient partners to ask and to have conversation with their family. And you mentioned that before, and to opening the conversation within one's family is not easy. Very often you say, you know, it's important, you should prepare. And the reaction is, oh, no, I don't want to talk about it. Not now, not now. Well, it's better to prepare, because when I do accompany a patient at the end of life, you realize how terrible it is that because the person didn't prepare herself or himself, the family at the time where in fact they should be giving love and be more peaceful and doing whatever they want to do with their loved one, they have to take those incredible decisions, and it's not the time. End of life is the time to live truly. It's the time to take care of one another, and it's really sad to see that we spend those last moments taking decisions that we don't know, and we are stressed, we are terrified, we are in a lot of pain. And yeah, I remember that I participated at the University of Montreal to starting conversation. And I remember that what we did is we have a toolkit and so on, and we prepare and we went to notaries. There was a big office of notaries, and we prepared them. They're the ones who know a lot about death. But I remember when we started that, it was like they didn't know anything. And it was a mind opener, quite frankly. And then we started with students also. A student at the University of Montreal, the young medical students who they think, you know, they're starting. And then when they start talking about death, there was a big malaise. I'm sorry, I don't know how to say that, but there was something that a feeling that they didn't like about it. And unfortunately, in our society, death is almost like a bad word. It's almost, it's taboo. You don't want to talk about it. You're scared of talking about it. And it's a shame, because the only reality and the only, how do you say that, real thing is that all of us are going through that. So I guess I'm gonna stop here, just because it's really overwhelming, and quite frankly, I think we should, all of us here today, maybe we should start a nice conversation in our own family if it's not already done. So have a good afternoon. Thank you.
Thank you, Ghislaine. We're going to now start the question and answer. And you're absolutely right. I was very pleased to see this topic as one of our seminars. What most people don't realize is that in primary care, we deal with the whole full spectrum of living and dying. And some of my own research touches on the death of children, which is even more taboo in our society than death in general. It's a very westernized perspective to see death as an enemy and something that needs to be delayed and defeated. And it does cause a lot of grief to families and to others. So I'm going to ask all of our panelists to turn their videos back on so people can see them. So I think in all of this research that we're talking about and what has been going on, and what we heard from Ghislaine, who is on the patient side, partner side of it, but also very critical lived experience. I think one of the things is we get into very tricky situations, and COVID has really brought this to the forefront, because now we're talking about allocating resources that are life and death decisions. So some of our questions, we got a few questions here, and one of them is about the do not resuscitate. So obviously around the planning and everything, do not resuscitate orders play an interesting role. Anyways, I'm not, I think sometimes what's difficult in this conversation is the time frame. Whether you're talking about somebody who has found out immediate that there's, and this is in their immediate future, or somebody who this is something that could be coming up within a certain amount of time. So thoughts on the DNR and how they differ between provinces and problems that can create. So I'm not sure who to direct this to. I think, sorry, I'm just thinking this over here. So who would like to volunteer on, did you find any of that in your research? Robin?
I don't feel like I'm able to answer that, to be honest, because I don't know. I wouldn't know what it is in other provinces. I mean, I don't, Alex might know now in our health authority, but a number of years ago, even just in Nova Scotia, not every place called it a DNR. It's a bit different. So I wouldn't be in a position to be able to talk about cross Canada, that's for sure.
Yeah, I guess that's one of the issues, right? That shouldn't technically vary, but you don't know what your local community might be doing. It was very interesting, the role of paramedics, because the DNR should come in a lot sooner into, because there can be extreme measures taken during the transfer to hospitals or different things like that, or people that don't want to go to hospitals. So I guess we, for the person that answers that, we don't have an answer for you. I think we'll just flag that as something that needs to be much the same way that the topic was brought up, that these conversations need to be happening and be normalized, so that they don't feel like they're taboo, or they aren't really stressful. Well, they'll always be stressful, but they won't be so distressing for people if we can start with something like, can we standardize these sorts of activities across provinces, then maybe we can make those conversations a little easier. They'll never be easy, but there's a difference between easier and easy.
Well, I think
Okay.
it is very hard. I think I just want to confirm, the idea of people doing plans early and having conversations early. And even though when you get into the hospital, having sisters that died, when you get into an ICU and someone wants to do an intervention, and as a family member to feel supported in your support of your family member to say no. These are all difficult situations. I mean, regardless of there are different legislations, different ways of working, but I think if the patient and the family have had those conversations and can feel strong in supporting the person who is dying, I think that's a good start, regardless. I mean, I think that we all come into situations we don't expect, but I guess that's like I said, I don't want to get into the legalistic of the different, things across provinces. They're all going to be different. The, ICU is going to be different, paramedics, and different provinces have different, they're all different regulations, but I think to push the envelope, so that I think that's our goal, is to get that support and people to just saying, I mean, that whole thing about, having the compassionate communities and normalization of death, I think is just huge. So we're looking more upstream in that piece, but I think just get that planning going and get the fact of like, let's not I know I don't even know if she's still there, but one of my research assistants, Jody Langley, was saying she has these conversations with her parents and they won't talk about it. And
Mhm.
so, I don't know, we just have to keep talking about it. So
I think that is a challenge, and that's one I've seen recently, and I'm very grateful that I don't have in my own family. But this notion where you have differences between willingness to openly acknowledge and discuss this and plan, and whether that is the person themselves who is dying or a close family member like the wife or one of the children. Yeah, I think this is where we absolutely need to normalize these conversations, because when you're in the situation, you feel very, very isolated and alone, and you feel like you're the only one going through it. And I know this from my engagement with parents whose children have passed. They really felt like, and they felt like after a while, nobody wanted to talk to them because nobody wanted to have that conversation and they didn't want it to continue. And it's like, so I think this notion around what can we do to normalize this, what can we do to raise a profile of both the research and the care is super important. And this is one of the situations, and I'm going to ask you, this touches on the last question that's posted. I'm going to ask you about your thoughts on this, because COVID has done two things. It's raised the death rate. So we need to, anytime you get diagnosed, it's something that's going to go through somebody's mind. It has also brought us to the really heartbreaking situation that should not ever have occurred in the society of our wealth, which is where people are going into hospitals and doctors or treating healthcare providers have to decide who's going to get the ventilator. And there doesn't seem to be any, these decisions are being made. And it's a fear for anybody who would be going in who might be older and who might not make the right priority list, which is what I think is disgusting and appalling and should never even be an issue, but it is. But I think what's happening, because we're in denial, we're shutting down these conversations. We don't want to talk about our loved ones going in the hospital and possibly not coming home. We don't want to talk about like who's getting a ventilator and who's not. So I think these decisions are being made and we don't know how and by whom. So what are your thoughts on, because I really think that COVID has brought this to the forefront, that a discussion that needs to be had, not so much in terms of how badly we've mismanaged our resources, that it is a discussion, but just this discussion about who is making life and death decisions, and how are they getting made. And I will give first prerogative to Ghislaine. Ghislaine, did you have was that a hand up to indicate, or?
Yeah.
Okay, go ahead.
Actually, I am part of the prioritization with the Health Ministry of Quebec. So I'm only talking for Quebec. And we have to understand, of course, that this is only if 200% of the hospital are at full capacity. So it hasn't been used so far. It hasn't. But the thing is that, and I'm part of that as a patient, and the thing is that I don't want to talk about ages, but in fact, yeah, whether we want it or not, ages is a factor, because we know that as we age, we have a lot of medical problems and so on and so forth. We are weaker and so on. But to answer the question of the over there is that, in fact, the decision should be done by 3 persons who do not know the person, who doesn't know the patient, first of all, who doesn't see the patient either. They don't have anything to do, they're just reading. And they have to choose between, in fact, the goal is to make one person survive. It's the person who has the best chance of surviving, of continuing living and being healthier. That's the choice that is done. So obviously, if you are maybe like my age, with all the illnesses that I have, I know very well that if I should be in that circumstances, probably I won't make it. So whether we like it or not, they said the age is not a factor, but the reality of the life of a person is that as you grow older, you're weaker. Your system going through a ventilator has been there, others have been there. It's not, it's very difficult. It's horrible for the body and so on. So the older you get, the more difficult it is.
So I wanted to, the people attending or the panelists may not know, may not be aware, but a lot of our current ethics, clinical ethics and research ethics are based on what was called the God committees. I'm forgetting the decade that was done. It was when dialysis was first invented and there was extremely limited resources. So these committees essentially decided who would get that. So who would live and die. And if you saw the criteria, you would be horrified. Put it this way, you needed to be an employed white man of good standing in the community to make the top of that list. So I would like to think that we have evolved since that point. And I was glad to hear Ghislaine's talking about people are actually thinking this through now and how you do this. I'm still concerned about how we view, like there's one thing about the likelihood of survival, but I'm concerned about how we view people's relative contribution to society and how we value that in these decisions. So I'm going to ask our other panel, but it's fascinating to me that as I do some bioethics work, it's fascinating to me that we're back in this 1950s, we're back to the God committees. And I just hope they're a little more sophisticated. So thoughts from our panelists. So Fred's telling me we are more advanced and that I can stop like drawing horrifying parallels. But other thoughts from the panelists about what we might need to contribute in terms of research to ensure that we are, it's very interesting to me. I think we never thought we'd get to the point where we would be having to make these decisions about resource allocations.
I might just, I guess, echo Fred's point. I really do believe that we've moved past that. I'm sure we could always do better. But that we actually, these types of decisions, not to the magnitude of COVID, that COVID has really highlighted, and who gets the ventilator and who is left to be given, morphine for comfort until they die of their COVID disease. But decisions around resource allocation and what we can afford in our public payer healthcare system are made. And the important thing that I think that Ghislaine has really highlighted nicely is that they're made at a policy level by diverse groups of people, including members of the public who represent the patient and family interest. And they're not made with one individual person in front of you. Now, sometimes they have to be, and you bring the ethics committee in and 3 practitioners who have to agree and that sort of thing. But it is far better to make those decisions without a person looking at you. That you don't have to look them in the eye and say, you aren't getting that ventilator, but instead that you've made these policy level decisions that that society can agree to and has had a chance to have input into about how we would, in the awful situation where we couldn't give that resource to everyone, how we would allocate it. But even decisions around what kind of medications our pharmacare system is going to pay for are made all the time. They're just not as dramatic as what we're talking about now. Oregon, many years ago, is a fantastic example of where they actually got together as a society and decided what kinds of medical treatments they would pay for. Not with one little child in front of them and do they get the cancer treatment 4th line or not, but would that circumstance qualify for public or for funded care? And I think that that's key, is that it has to be, it's so hard when there's a person in front of you. And we talk a lot now in the medical community about the moral injury of having to make that kind of decision when you're looking in the eyes of this person and trying to decide whether this person is going to get the treatment or not. To make it at a policy level and to make it with the public involved as well, not just a couple of physicians behind closed doors.
That's very interesting. And I think then Roger has commented in the questions that you still get into a sticky wicket when you have 2 people that look alike according to these guidelines and you still have to make the decision. So then I think that this is where what I call real life ethics hit policy ethics, and occasionally we are left in a very, very difficult, challenging situation. But I think that probably occurs in medicine more often than we would like to think. Robin.
I was just going to say, I would like to frame it a little differently, even at the individual level, because I don't want to say that, they or the physician or whomever is making the decision. I mean, it should be also shared decision in terms of, if you're taking COVID's an extreme example, right? But there are risks and benefits of most of the interventions that we will ever give. And so they're also not just like one person's decision. And when I say one person, the healthcare provider or the physician, it should also be a shared decision. I mean, if you think about someone, and I'm not talking about resource allocation now, I'm talking about if you think of someone who maybe has severe frail, who has a high level of frailty and comes in with a pneumonia, or I don't know, or COVID, a severe case of COVID. And, I still think that the decision to go on a ventilator needs to be made with the person knowing the risk and benefits of that decision. So it's not just like the physician's decision. So I just wanted to frame it a little bit and think a little more broadly around that. I think it needs to be made with the person. And if the person is unable to, the family as well. And the discussion. Yeah.
And to wrap that back around to our first question around the DNR, and one thing we did find in our research, whatever you call it, is that one of the strong recommendations out of the research was that it needed to address more than just if your heart stops, do you want us to pump on your chest and do CPR for you? It needed to address all the health crisis that could come before that. Would you want an intravenous antibiotic trial? Would you just want us to keep you comfortable? Would you want to go into an ICU or not? And to encourage those decisions and discussions to happen with family members. And failing that, the other way we can approach it is often to frame it as, what do you think your mom, your wife would have wanted if she could tell us right now? Would she want us to do this? Knowing that this is the likely outcome of that intervention and this is what her life is going to look like after that. And those are important conversations. I really like the whole speak, who will speak if you can't speak for yourself, and make sure they know what to say kind of campaign that's come very, because whether it's COVID or something else, and back to Roger's initial question around, what have we found about that, is that, and it needed to be in language that everyone could agree kind of meant the same thing. So we had found that it needed to have words that the doctors would understand and know what you meant by that and what we were supposed to do, but words that the family could understand so that they knew what they were agreeing to as well.
So all of that, I'm going to wrap, we're coming towards the end of our time. I need to wrap it up. This is a fascinating conversation. I think all of this indicates that we need to normalize these conversations. We need to have them. We need to understand people's perspective. And I would think clarity can only ever help. And for me, it's fascinating because a large part of my research focuses on how do people balance quality of life considerations over our current medicalized focus on survival at any cost. And I think that the end of life part, what will your life look like? What will those 3 months look like? Is that something there? And it's interesting, Ghislaine mentioned the intubation. I think everybody I've spoken to that's been through it are like, I'll give that a hard pass. So there is a huge quality of life issue. And yes, Roger, we'll finish with Roger's comment about quality versus quantity. Thank you all for your fantastic work and for participating today. Thank you, especially Ghislaine. This is time out of your day that I really appreciate. Jessica, for being here from Brick, Nova Scotia. The attendees will be sent a survey to ask you about what you thought of this. Also, if you have ideas for future sessions. And I believe our next session is on April 27th. And we're going to talk about how patients can evaluate their experience in primary care and how they perceive the outcomes. Because often what we do on the medical side is very different from what people actually would like and are expecting, and really relevant for today's topic as well. So nice segue into prems and proms in primary care healthcare. So if you want to know what the acronym is, you need to show up on April 27th. Okay, thank you everybody, and thank you all of our attendees.
And thank you,
for
Jill.
an excellent session.
Thank you.
Wonderful to see you all. Have a good
Bye.
afternoon.
Take care,
Bye.
everyone.